lungs, role in acid-base regulation. The lungs play a critical role in the body's second line of defense in maintaining acid-base balance. This dynamic system works alongside the buffer system to regulate pH by modulating carbon dioxide (CO2) levels, which influence the formation of carbonic acid H2CO3. Here's how it works. 1. Mechanism of action. Acidosis. In a state of acidosis, low pH, the body perceives an excess of hydrogen ions, H prize, and acidic compounds. To compensate, the respiratory system increases both the rate and depth of breathing, hyperventilation. This facilitates the exhalation of CO2, a component of carbonic acid. Reduction of CO2 shifts the equilibrium, text H2CO3 HTO2 exhaled. This effectively removes hydrogen ions, raising the pH. Clinical correlation. In conditions like diabetic ketoacidosis, a compensatory mechanism called Kussmaul respiration, deep, labored breathing, is observed to blow off CO2s. In alkalosis, high pH, there is a deficit of hydrogen ions. The body slows down the respiratory rate and depth, hypoventilation, to retain CO2. Retaining CO2 promotes the formation of H2CO3, which dissociates to release hydrogen ions, lowering the pH and countering alkalosis. Clinical correlation. Conditions such as hyperventilation syndrome can lead to respiratory alkalosis due to excessive CO2 exhalation. 2. Speed and limitations. The respiratory system can respond to acid-base imbalances within seconds to minutes, making it the fastest compensatory mechanism. However, the lungs can only regulate hydrogen ions associated with carbonic acid. Imbalances from non-volatile acids, e.g. lactic acid, ketoacids, require renal compensation. Monitoring clinical signs. In compensated acidosis, monitor for increased respiratory effort and potential fatigue as the body tries to maintain balance. In compensated alkalosis, shallow breathing may signal the body's attempt to retain CO2. D. Kidneys, the primary long-term regulators. The kidneys provide a more comprehensive response to acid-base disturbances compared to the lungs. While slower, taking hours to days, renal compensation is more thorough and precise. 1. Mechanisms of renal compensation. Acidosis. In an acidic state, the kidneys, 1. Secrete excess hydrogen ions into the urine. 2. Combine hydrogen ions with urinary buffers, e.g. phosphate, ammonia, for excretion. 3. Retain bicarbonate ions, HCO3 to restore buffering capacity. Clinical correlation. In chronic respiratory acidosis, e.g. COPD, renal compensation results in elevated serum bicarbonate levels. Alkalosis. In an alkaline state, the kidneys, 1. Excrete excess bicarbonate ions in the urine. 2. Retain hydrogen ions to increase blood acidity. Clinical correlation. In prolonged vomiting, loss of gastric acid can lead to metabolic alkalosis. The kidneys compensate by excreting bicarbonate. 2. Selective bicarbonate regulation. Bicarbonate is reabsorbed or excreted based on the body's needs. Hydrogen ions combine with phosphoric acid or are converted into ammonium ions, NH4+ for excretion. 3. Monitoring clinical signs. Monitor urinary output and composition, pH, ammonium levels to assess renal compensation. Be alert for conditions like renal tubular acidosis or excessive diuresis, which can impair the kidney's regulatory capacity. Potassium. Its crucial role in acid-base balance. Potassium, KTs, acts as a key player in maintaining acid-base balance through its ability to shift between intracellular and extracellular compartments in response to hydrogen ion concentrations. 1. Mechanism of transcellular shifting. Acidosis. Excess hydrogen ions in the extracellular fluid, ECF, move into cells to reduce acidity. To maintain electrical neutrality, potassium ions exit the cells, leading to hyperkalemia, high serum potassium. Clinical correlation. Hyperkalemia can cause cardiac arrhythmias. This is often observed in conditions like diabetic ketoacidosis or renal failure. Alkalosis. Hydrogen ions move out of cells to counteract the alkalinity of the ECF. Potassium ions move into cells, resulting in hypokalemia, low serum potassium. Clinical correlation. Hypokalemia can cause muscle weakness, cramps, and arrhythmias, often seen in patients with prolonged vomiting or diuretic use. 2. Interdependence with acid-base imbalances. Potassium disturbances are both a cause and effect of acid-base disorders. For example, treating metabolic acidosis with sodium bicarbonate can exacerbate hypokalemia, necessitating close monitoring. 3. Monitoring and clinical implications. Always monitor potassium levels in patients with acid-base imbalances, as abrupt shifts can lead to severe complications like arrhythmias or neuromuscular dysfunction. Key takeaways for clinical practice. 1. Lungs, rapid but limited compensation, primarily addressing CO2-related imbalances. 2. Kidneys, slower but comprehensive compensation, addressing all acid-base disturbances. 3. Potassium plays a dual role, requiring vigilant monitoring to prevent complications. Understanding these mechanisms helps clinicians tailor interventions, such as adjusting ventilation settings or electrolyte replacement, to stabilize acid-base balance effectively. Case presentation 1. The role of the lungs in acid-base balance. Scenario: uncontrolled diabetes leading to metabolic acidosis. Patient information. A 45-year-old male with a history of type 1 diabetes presents to the emergency department with confusion, rapid breathing, and abdominal pain. Clinical findings: blood pH 7.25, acidotic, bicarbonate HCO3 14 millidecor low, partial pressure of CO2 PaCO2 25 millimeters grams low, compensatory mechanism, respiratory rate 32 breaths per minute, tachypnea. Clinical course: this patient has diabetic ketoacidosis (DKA), a condition characterized by the accumulation of keto acids. The lungs compensate by increasing respiratory rate and depth, Kussmaul respiration, exhaling more CO2 to reduce carbonic acid and partially correct the acidosis. Management: intravenous fluids and insulin to halt ketone production. Monitoring arterial blood gases, ABGs, to track respiratory compensation. Key teaching point: the lungs can compensate for metabolic acidosis within minutes, but they cannot correct the underlying cause. If hyperventilation fails or the patient fatigues, mechanical ventilation may be required. Case presentation 2. The role of the kidneys in acid-base balance. Scenario: chronic obstructive pulmonary disease, COPD, with respiratory acidosis. Patient information: a 68-year-old female with a history of severe COPD presents with increasing dyspnea and lethargy over several days. Clinical findings: blood pH 7.32, mild acidosis, PaCO2 60 mmHg elevated, respiratory retention, bicarbonate HCO3s 30 mmHg elevated, renal compensation. Clinical course: this patient has chronic respiratory acidosis due to impaired CO2 clearance from her lungs. Over time, her kidneys have compensated by retaining bicarbonate and excreting hydrogen ions to restore pH toward normal. Management: optimize oxygen delivery without suppressing respiratory drive, e.g. low-flow oxygen. Bronchodilators and corticosteroids to improve airflow. Monitor for signs of acute decompensation, e.g. hypercapnic respiratory failure. Key teaching point: the kidneys play a vital role in long-term compensation for chronic respiratory conditions, but this process takes days to fully develop. Renal compensation can be overwhelmed if the underlying respiratory pathology worsens. Case presentation 3. Potassium shifts in acid-base imbalance. Scenario: hypokalemia and metabolic alkalosis. Patient information: a 30-year-old female presents with fatigue, muscle cramps, and frequent vomiting for 3 days after a viral gastroenteritis episode. Clinical findings: blood pH 7.48, alkalotic, serum potassium 2.8 mmHg low, bicarbonate HCO3 30 mmHg elevated. Clinical course: this patient has metabolic alkalosis due to loss of gastric acid, hydrogen ions, from persistent vomiting. To compensate, her cells release hydrogen ions into the extracellular fluid, forcing potassium into the cells and resulting in hypokalemia. Management: potassium chloride supplementation to correct hypokalemia. Intravenous fluids with normal saline to restore intravascular volume and promote renal excretion of bicarbonate. Address underlying nausea and vomiting. Key teaching point: in alkalosis, cellular shifts of potassium can exacerbate hypokalemia, which must be corrected to prevent complications like arrhythmias and neuromuscular dysfunction. Case presentation 4. Hyperkalemia in metabolic acidosis. Scenario: renal failure with metabolic acidosis and hyperkalemia. Patient information: a 55-year-old male with end-stage renal disease, ESRD, on dialysis presents with generalized weakness and irregular heartbeat. Clinical findings: blood pH 7.20, acidotic, serum potassium 6.5 mmHg elevated, bicarbonate HCO3 means 15 mmHg low. Clinical course: This patient has metabolic acidosis due to the kidney's inability to excrete hydrogen ions and reabsorb bicarbonate. The acidosis drives hydrogen ions into cells, forcing potassium out into the extracellular space, resulting in hyperkalemia. Management: emergency hemodialysis to remove excess potassium and correct acidosis. Administration of calcium gluconate to stabilize the myocardium. Sodium bicarbonate to buffer the acidosis and shift potassium back into cells. Key teaching point: hyperkalemia associated with metabolic acidosis is life-threatening and requires prompt intervention to prevent fatal arrhythmias.